Good morning. I'm Gordon Smith, the state's Director of Opioid Response in Governor Janet Mills' office. Thank you for joining us today for our monthly opioid response webinar. And today's topic is the statutory overdose review panel. And we have a terrific faculty that I'll introduce in a moment. The next webinar will be November 3rd, and we'll be featuring the data from the Northern New England Poison Control Center. The clinical director, Karen Simone, will present that data on what gets reported to them that's of interest to those of us who work on drug policy in the state. I want to mention that last month's webinar with the featuring the projects of the EMS office, we had way more questions than we had time to answer, and they've now all been answered in writing, and those will be placed on our website at the AdCare server by early next week. If you have questions today during the webinar, please feel free to put them in the question and answer box as opposed to the chat box. Let me introduce our faculty today, and then I'm going to have Dr. Springel say a couple things before turning it back to me to give you the context of this review panel and the law that established it. Dr. Springel is a retired physician who is also serves currently as executive director of the Maine Association of Recovery Residences. He's really worked very closely with me on the state's opioid response ever since we started in February of 2019. Also joining us is Dr. Marcella Sorg, a cultural anthropologist from the University of Maine team at the Margaret Smith Policy Center. Dr. Sorg has been the primary person putting together the data from the overdose deaths for way before I started in 2019, and is a wealth of information. And her team staffs the overdose review panel that we're going to be talking about in a moment. We also have with us today Shelley Yankowski, who with Dr. Springel does the interviews with next of kin frequently, or other people that are willing to talk to us about the deep dive cases that we've been working on. But first, a little announcement from Dr. Springel.
Oh, thanks, Gordon, and good morning, everyone. As we've been doing the work on the review panel, we have been warned about what's called vicarious trauma. That sometimes that you're studying trauma that happened to other people, and it can bring up things from one's past, can create some emotional tumult as we discuss some of this material. That's possible that some of you in the audience may feel that today. So we wanted to include that, as you could think of it as a warning or a caveat that triggering can occur during some of these discussions. So that's just a note to be aware. And if you find yourself diving into one of these emotional rabbit holes, we encourage people to get help around that, to seek support, and Shelley and I will be talking about some of those resources later.
Thank you, Ron. I also, before diving into the panel, wanted to call your attention to the August overdose monthly report that's cumulative, so it has data from starting in January and comparing data to the same period in 2022. And there is a piece of good news in this, in that our mortality compared to last year continues to be down about 10%. The bad news, of course, is that still represents 409 people who had died as of the end of August. We all understand on this webinar that that's way too many people. It is better than the fact that 461 people as of this point in time last year had died. So it's good to see the number improving. I'm not going to talk about the total number of overdose deaths, which probably this year will be about the same as last year, about 10,000 overdoses, of which nearly, if things continue in the way that they have continued, about 94% of these individuals will survive their overdose. And our job at the state, among our jobs, is to make sure that those people get connected to services, the harm reduction services or recovery services, connected to people. So again, with that brief introduction, I'm going to tell you about the law that passed in 2021, excuse me, that set up the accidental overdose death review panel. Several states have similar panels, and in drafting the statute, we looked at the 6 panels also in Maine that already review certain deaths. There is a domestic violence and homicide review panel. There is a Maine elder death analysis review team. There's a maternal, fetal, and infant mortality review panel. There is a child death and serious injury review panel. There is a death involved, there's a panel that looks at every death involving use of deadly force. And there's an infant safe sleep coalition that also reviews any death associated with unsafe sleep of an infant. So we examined all those. There's a certain features of all those. The work is generally done confidentially so that people identity is protected. They generally have the authority, as we do under our statute, to collect records from treatment providers, from schools, from just about anywhere, unless there's an overriding federal law that prohibits us from obtaining that information. The legislation was actually presented in the year 2000, just before the public hearing was to be held on the bill. COVID shut down the legislature, and so it didn't get considered until 2021. But it was enacted, signed into law by the governor, and the appointments were made quite quickly. The panel members gathered for the first time in the fall of 2021 have met about 14 times, including for 3 hours this morning. Generally meet now every other month for 3 hours on the first Friday of each month. The purpose of the panel is to recommend to the state, county, and local agencies methods of preventing deaths as a result of accidental drug overdoses, including modification or enactment of laws, rules, policies, and procedures. The accidental drug overdose is defined as an overdose that's presumed to be self-administered by an individual and excludes any overdose that occurs within a licensed healthcare facility. The reason for that is that there is already a different process to review an overdose death, for instance, in a hospital. And we've had, of course, some of those. Those are reviewed by a panel at licensing and certification, the group that licenses hospitals. They're considered a critical incident. The 15 people, some of them are statutory positions. The terms are for three years, and there's no prohibition in the statute from a person being reappointed. And our 3-year terms will run out for most people about a year from now. So the members of the panel are the chief medical examiner or his designee, and he's designated a prior chief medical examiner, Peggy Greenwald. Dr. Greenwald sits on the panel. The Commissioner of Public Safety, Michael Sofchuk, the Director of Behavioral Health, or her delegate, and Director Squirrel has designated Catherine Coutu, our state opioid treatment authority, as the member. The Director of the Maine CDC and Dr. Shah and now Dr. Var have asked Isaac Benowitz, Dr. Benowitz of the Infectious Disease Division to serve. The Chief Justice of the Supreme Court has appointed Judge Matthew Tice. Justice Tice has been with us since the day one. A prosecutor was Jonathan Sarbeck, and now Natasha Irving from the Knox, Waldo, Lincoln, Saginaw District. Police chief nominated by the chiefs is Bob McKenzie down in Kennebunk, known to many of you, certainly known to us. Sheriff nominated by the sheriffs. It was Troy Morton in Penobscot, and now it's Todd Brackett from Lincoln. And this morning, the chair of the Sheriff's Association, Dale Lancaster, sat in for Sheriff Brackett. We have one or more treatment physicians. We have Vijay Amarendan, an addiction psychiatrist in Portland, and Mary Dowd, who is one of the medical directors at Milestone from Portland. An emergency medical services representative, that's Director Sam Hurley. An expert in harm reduction is Patty Hamilton from Bangor Public Health. An academic research professor with experience in reviewing drug overdose deaths, appointed by the Attorney General. The Attorney General Fry appointed Dr. Sorg. So she not only is on the panel, but also is responsible for staffing the panel through a contract with the Margaret Chase Smith Policy Center. A representative of families, that is Shelley Yankowski with us here today. A person in recovery from substance use disorder, that's Dr. Springel. And I, as the Director of Opioid Response within the Governor's Office of Policy Innovation in the Future, I am a member ex officio, and I chair the panel by statute. I think I'm going to ask Dr. Sorg to take you through really the process, particularly of how the cases are selected. The real purpose of this group is to do a deep dive into individual cases and to acquire all the records associated with those cases. I think it's been extremely valuable. We have made recommendations after each case, and Dr. Sorg will talk about that. Those recommendations will be made public soon. We'll be publishing also an annual report that will be really a report of our first 2 years very soon. But the ability to get behind underneath just a number and examine what happened, what was the life of this individual like from the time they were born until they died prematurely of a drug overdose. And what can we learn from that experience is, I think, extremely valuable. It's not lost on me that all 15 members of this panel show up for these 3-hour meetings, and it takes at least 3 hours to review all the materials associated with the case. So I think we feel that that we're really getting a lot out of it. We have some important recommendations to make. And I'm going to turn it over to Dr. Sorg to show you some slides and talk about the process that we use in picking these cases and in reviewing them. Dr. Sorg.
Thank you, Gordon. I'm going to immediately share my screen. And you should be seeing the screen at this point.
We can see it. We can see it.
And as Gordon said, I'm going to talk a little bit about the process. I'm going to talk a little bit about the medical examiner's office that I work with very closely, and about how some of these cases are investigated. Gordon already went through with you the details of LD 1718, and as you now know, We've been in operation for 2 years, almost exactly 2 years. And one point I want to make is the last bullet there on this slide, that we can review both fatal and non-fatal overdoses. And this is different from other states, and it's more broad. We have not as yet done any non-fatal cases, but we probably will do that in the future. There are other attendees besides the panel who come to the meetings, and some of them are on an as-needed basis. State officials may attend if we need their advice about something, or data managers at the state level. The humane support staff are all there, and there's a handful of us. And stakeholder guests are also invited. And I want to make sure to mention that all of those have a written confidentiality agreement before they attend the meetings, as do all of the panelists. The administrative support staff from Humane does several functions here. We prepare the case for the panel review, and this is a major process. It involves going out and finding sources for a lot of data pieces that may not already be part of the medical examiner's case file. It includes medical records, psychosocial history, criminal justice records. We do interview family members, as you will hear shortly. We prepare an abstract, which includes a timeline of what happened during this person's lifetime, along with the details from the reports, which the panelists have access to. And we share all that digitally, and it's kept in a secure location. We facilitate the meetings, and we prepare an agenda, we moderate. And as I said, that one of the most important things is maintaining confidentiality and information security. We also have, as part of our team, the coordinator of the suitors data set, and that program is a program that reviews all of the drug deaths for the federal CDC. There are some 600 variables in that system, and so we have collected a lot of data at the state level that are part of federal data sets, and sometimes we need the coordinator to answer our questions about what data we do have access to and what data we don't. In terms of this process, how do we select the cases? Our team has been dealing with the data for some time, and we are aware of some of the patterns that are showing up in the data. And so we can suggest possible types of cases to review. Panelists also bring their ideas in and suggest certain types of cases. And then sometimes we go through a set of cases that one of our team members brings from the suitors program, and the panel selects which cases are they going to review in depth. The case categories, for example, include recent release from incarceration. We did that category first, and the percentages from the suitor system are shown here on my slide. 2.4% people who, of the drug deaths, were people who died within 30 days of being released from incarceration in jail or prison. In 2022, that number was 1.7%. Recent release from hospital, and again, that's within 30 days of their death. And in 2022, that level was about 16.2% of the decedents from 2022 that were recently seen in the hospital for some reason, not necessarily an overdose, it might be some medical problem. The preliminary case data are collected by the Office of Chief Medical Examiner, and that includes the suitors data. It includes quite a lot of data that is provided by statute for the medical examiner to collect, including, for example, the medical records. And I just wanted to say a little bit more about how we investigate these deaths in Maine. Any death for which the death certificate mentions a drug as a cause is included as a drug death. Now, most of these, a vast majority, are accidents, and that's what the panel is going to be focused on. These are unintentional deaths. They do not include suicide by overdose, and they do not include homicides, which would be a death at the hands of another. The title of the panel is Accidental Overdose Death Review Panel. But as I mentioned, we do have the statutory authority to review non-fatal overdoses. The cause of death is very complex. We're looking for things that affect vital systems, but other medical conditions they may have also affect vital systems. And those medical conditions might also be included as part of the cause of death. And if the medical examiner finds natural disease that increases the risk of dying in the presence of drugs, they might include, for example, cardiovascular disease or cirrhosis of the liver, something like that. By statute, the Office of Chief Medical Examiner investigates all, that's 100% of drug deaths in Maine, to identify a physical cause of death and to identify the manner of death, which means natural, homicide, suicide, accident, or undetermined. Most of the cases receive a physical examination. A minority of the cases receive an autopsy. These are for more complex cases. And all cases receive a very comprehensive toxicology examination, usually a sample of blood, and it really covers a wide range of both pharmaceutical and non-pharmaceutical drugs. And in most of the cases these days, multiple drugs are involved. The average is 3. The medical examiner decides which of the drugs may have caused the death among the ones that are in their system. And sometimes there are multiple drugs that act together. They are additive or synergistic in their effect. And so taking both of them has more effect than if they just took 2 separately. Example would be central nervous system depressants. So fentanyl, oxycodone, and alcohol would all be central nervous system depressants and would be included together on the death certificate. We are seeing patterns, but I want to emphasize that individuals and their circumstances are in fact unique. These are accidents. It's a combination of circumstances that come together at that moment to increase the risk of dying. The big players in this system include fentanyl, which is involved and causes 80% of the drug deaths. And that has really been a game changer because it acts so fast that, and with such a small amount, that it's very difficult to get to the person in time and give them naloxone. Also, 80% of the overdose deaths are unwitnessed. That means that nobody was there at the moment that they took the drug, and 80% of the time it's a fentanyl. And so since fentanyl acts within minutes, it's really hard to administer the naloxone in time. If you don't find them within minutes. So when the panel gets busy with these cases, we're looking at the cause of death, all of the circumstances, and the characteristics of the person that died, as Gordon mentioned, things that are connected to drug use and the circumstances of death. And that can include mental health problems, physical health problems, social circumstances like housing insecurity, traumatic events in their childhood, and the history of drug use and drug treatment. Already, the medical examiner has in their files, the medical examiner and autopsy reports, a police report, which is by statute has to be given to the medical examiner in these cases. The EMS report, if EMS was involved, the medical records are just the most recent period. The medical examiner doesn't go back through everything, but we tend to go through everything as much as we can. The toxicology report, and a report from the prescription drug monitoring program. And so we access other older medical records, arrest records, court and incarceration records, DHHS records, and interviews with family members, as we will be hearing from Dr. Springel and Shelley Yankowski in a moment. We start with the medical examiner files and then expand outward from that. The records are solicited, and this takes time and accumulates a lot of paper. There's some of them that are just inches stacked up. There's a lot of records to go through, which need to be summarized and abstracted. So we did 2 topics recently released from incarceration. We've completed 5 cases in that category. And the recently discharged from a medical facility, we've completed 5 cases as of today. We have the administrative report that is an output that Gordon mentioned. And that will include some recommendations, which will be handed to the appropriate agency as the decisions are made about how the recommendations will be shared by the Attorney General and so forth. And that's all I have. If there are questions, be happy to. I think we're going to have questions at the end of these presentations.
We will do questions at the end. Go right ahead, Ron, with your presentation and introducing Shelley as well.
Oh, sure, Gordon. Thank you very much. I think we will be discussing some of the proposed recommendations later today. Again, my name is Ron Springel. I'm a person in recovery from opioid use disorder for a number of years. And I have the pleasure of working with my partner in crime, Shelley Yankowski. We're the 2 members appointed by the governor with lived experience of one kind or another. Shelley's an affected family member, and she'll describe that in a minute, and myself as a person in recovery. And when the panel started 2 years ago, we looked around the country to what other states were doing around next of kin interviewing. And we found that not many were doing it. On the other hand, there is formal training available through the federal government from the Bureau of Justice Assistance, the BJA, and they actually make available formal training in next of kin interviewing. And Shelley and I had the opportunity to complete that training course. We found it extremely valuable. Interviewing next of kin of persons who have died accidentally from drug overdoses is really serious business. It's not a casual conversation. It involves significant preparation, not just knowledge of the record, but also preparing oneself in terms of knowing about the people you're going to be talking with. It is a mom and dad. Are they married? Are they estranged? Are they divorced? Are there children? Is it a stepbrother or a stepsister or a full brother or sister? What was their relationship like during the time that the deceased person, we call that the decedent, during the time he or she was alive? So these are all things that really need to be done ahead of time. And then we do try to schedule the interview. They've been primarily through Zoom, especially since they began during the pandemic. And Shelley and I learned very early on that we need to do these together. We can't do them one at a time. It's just our experience with these interviews is such that we both have a unique experience set of, that we bring to these interviews. Shelley's going to talk about the resources that are available to families and also to any others that may feel triggered by vicarious trauma, what we spoke about earlier. We interview families. It doesn't have to be a blood family. We like to speak to moms and dads. Sometimes they're not in condition to talk to us. They may be suffering from medical issues themselves, including active substance use disorder. But we still like to talk to as many of the close family members as we can, sometimes together. But this has to be cleared ahead of time. We can't bring family members together that have been warring with each other, whether it involves the death of their loved one or not. So we have to be careful there. We have to remember these families are still grieving, even if it's been a few years since the loss. The grief is still very close to the surface. Many of the family members are still angry, maybe not as angry as they were, wanting to kill. They've said, I want to find out who's responsible for the death of my son, and I want to kill them, or I did want to kill them. We hear that. They want answers. They want to hear details. And as Marcy and Gordon have said, we get hundreds, sometimes thousands of pages of records, amazing number of records, hospital records, and all kinds of things, everything you can imagine. And so we're privy to a lot of information obtained through the statute, through the authority of the statute, but we can't necessarily share that all with the next of kin. There are some limits to that. We would have a case where we may have a situation where a record indicates there may be a biologic offspring of the person who had died, and the family member may not have known that. So we sometimes have to tread carefully. The families not only want answers, they also want to share. They want to share about their loved one. The records tell us a lot about the person from a standpoint of what diseases they had and prescriptions and how many times they went to treatment or were in jail, but they don't really talk about the person, what they were like growing up, the challenges they faced when they were infants or young children, or in school, or about their love lives, or the things that they love, their personalities, and they want to tell us about that. And indeed, we want to hear, because that helps us to know more about that person, and can really inform the kind of recommendations that the panel makes. They also want to help. They want to help our work. Some have offered to be helpful to us in as many ways that they can. Interestingly, most have not reached out on their own for any type of independent help around grief or loss counseling, which we found to be pretty interesting. So I want to stop there for a second. I know Shelley has some comments to kind of round out mine, and then we'll go from there. Shelley.
Hi. Some of you may know, some may not. My husband and I lost both our children to overdose, our sons. And it gives me a unique perspective with this group, that I'm able to understand what a parent is talking about. I remember it was 6 and 5 years ago that they passed away, but I remember this yesterday or this morning. And I didn't have anybody to talk to about it. My husband and I did, but back then, 6, 8, 7 years ago, you kind of kept it a secret. You didn't want anybody to know. And that's still as it is today in a way, but a lot of people are opening up about it. And if I had someone come to me and say, hey, we'd like you to help us interview or investigate into your son's death or about your son, I would have been more than happy to talk to anybody about it. And I've learned a lot since they passed away, and I'm able to use a lot of the knowledge that I have with the family members to make them feel comfortable, even though they're in the worst time of their lives. Ron.
Thank you, Shel. Some of the things that we've discovered, if you will, that have come up in more than one case are identifying what we'll call danger zones. And the panels discussed this. It'll probably be part of our formal recommendations that there be some education around this, notifications, especially around treatment providers. But we've known there are certain danger zones that have already been recognized for overdose times that are particularly dangerous or vulnerable for fatal accidental overdoses. We know that upon immediate release from incarceration, when a person is returning citizen, that for various reasons, including one may be they don't have the protection of medication for opioid use disorder, but also because their tolerances have decreased and they decide that they want to use again, and they may use an amount of the substance pretty much in the same quantity as when they were at the end of their use before they were incarcerated, only to find that their tolerance to the drug has decreased significantly. And even if the same dose they had safely a few months ago, they now find themselves on death's doorstep or indeed deceased. So we certainly know that happens. We also know that after a person has had an overdose, whether or not they were taken to the emergency room, that period after discharge from the ED, usually just not an admission stay, but just admitted to the ED, that they're at higher risk to have another overdose and perhaps a fatal one. We've also seen, perhaps less well known, that when a person is on a waiting list, and we know that waiting lists are problems, that they want to have, we'll call it the one last hurrah, one more before I hit the road. We've had a couple of these cases where a person was scheduled to enter into some type of treatment the very next day, and they literally did not make it within hours. So we think that this is one of our lessons learned, that this is something that would be valuable, especially for the people making appointments, for folks to come in. Well, you're on the waiting list. Let me call you up. Oh, we've got a bed for you. Come in tomorrow. That might be a very good time to kind of run through a checklist about with the person. What are your plans for the next 24 hours? Who are you going to be with? What is your safety plan? Talking to a buddy or a partner can stay with them. There are things that can be done that I think, that we're not doing now. Also, a number of the family members were critical of law enforcement, and we take these seriously, of course, but critical in the way that law enforcement is so busy and so stretched for resources that it's very hard for them to always get back to the next of kin, to the survivors, with information, with sometimes even belongings, or to keep them posted on developments of the case. I mean, with over 700 fatal overdoses last year, it's literally impossible to do that. But we know that our Commissioner of Public Safety takes this very seriously and is doing what he can. But these are the kinds of things that come up in the family interviews that may not necessarily come up in other areas. Shel, anything else you'd like to share?
Quite often the family has questions about where they could get some therapy or some help, or how to get the medical examiner's information so that they can look at that paperwork as well. We've provided that information just about every time we've spoken to someone, and I often refer to the knowyouroptions.org for people, because it gives in every county. I'm in the Bangor area, Ron's in the Portland area, and sometimes the people we're interviewing are in Holton or Kittery. So it gives them every county has the information of where families can actually get help as well. And they seem very appreciative of that.
Most of us are aware of programs like Al-Anon family groups. In the Portland area, and also I think available by Zoom, is thefamilyrestored.org, thefamilyrestored.org, just one word, .org. And they have meetings really in Massachusetts, I think now New Hampshire, as well as Maine, that provide family support. It's not just for someone that has a living relative who's experiencing substance use disorder, but also for survivors of someone who has been deceased. By the way, we'd be remiss if we did not thank some of the staff at the University of Maine Margaret Chase Smith Center, Policy Center, Andrew Fournier and Alexandra Rex, R-E-Z-X. I never pronounced your name properly, Alex, so I'll just spell it for folks. Andrew and Alexander. They toil tirelessly in digging up records. And these are records that most organizations are not don't feel that they can give to us legally because of HIPAA and other laws. But the statute allows that. So we've had these battles sometimes with our partners in the medical community to receive these records, but that has gotten a lot better. It's a task that has its rewards, but we won't really see the fruits of our labor, I think, until recommendations come out, more people are educated, and that we see it reflected in the tragic statistics that Gordon and Marcy keep track of. And with that, I know there's some questions in the chat. Gordon, I think you've been working on answering them.
Yes, coming back on here, I'll start with the last question because it was very relevant to the panel's deliberation this morning. And here's the question, you may all want to weigh in on it. In terms of jail release, if someone has been incarcerated for a long time and some length of sobriety, why would they not be put on Vivitrol injections monthly rather than Suboxone? Vivitrol over several months really starts to heal the brain, and success to remain sober is much greater when released. I don't understand why, if folks have some length of sobriety, they would be placed on Suboxone. I think we could also substitute Sublocade. Those are all brand name products. Vivitrol is not exactly the same as Sublocade, but they're both injectable medications that help people deal with their cravings, obviously. And in the case of Sublocade, at least it lasts about 30 days. You're the only physician on the, why don't you start with that, Ron? And I wouldn't be surprised if I chime in afterwards.
Regarding Vivitrol and Sublocade?
Well, the basic question is that I think the person asking the question probably frustrated that she sees so many people come out of incarceration and Suboxone may have been treated with medication, but still use recurs and frequently they die, rather than having been protected for a longer period of time with an injectable form of buprenorphine.
Yeah, so the Sublocade, and we really call it injectable buprenorphine. That's a one brand name. There's other brand names coming out that are the same medicine. There are difficulties with family practitioners prescribing it. It has to be administered. There are issues around storage. It needs to be refrigerated. It outdates very quickly. There's some barriers around that make it more difficult to be widely available. But cost is a huge factor. If cost were not a factor, probably we'd be seeing 100% increase in people using Sublocade or injectable buprenorphine. But these are factors, and they have to be straightened out. Some people return to use simply because they haven't. Sublocade is really only just one tool in the toolkit, or buprenorphine in any form. The same thing with Vivitrol or naltrexone. Same thing. It's not the only thing you can build your pillar of recovery upon. That it's not connection. We know the opposite of addiction is connection. So the only connection you get with that is going to your doctor once a month. That's not nearly enough. We have to, change our people, places, and things, our places, really make radical changes in our behaviors. These don't happen with just an injection or a prescription.
Shelley or Dr. Sorg, do you want to comment? Hearing none, I would add that I want to talk a moment about the pilot at Somerset County Jail. The state has about nearly $1 million invested in offering Sublocade to any resident in the jail who has a diagnosed substance use disorder. It is the only form of medication for substance use disorder that's offered in that jail. And it was done, it's a pilot, but it's also done as part of a research project directed by Dr. Elaine O'Connor. And there is a test group that group of residents are compared to in terms of their experience leaving the jail. Sheriff Lancaster told us this morning that I think 67% of the individuals who were given injectable buprenorphine were able to make appointments for shots after they were released from the jail. So they didn't have to go back to pill or film version of Suboxone. The early results of that pilot are very, very promising. No one has fatally overdosed that's been a part of the project, and well over 100 incarcerated individuals have been given the injections. It's particularly valuable, of course, if the injection is given close in time to their release, because then they're going to be protected for the remainder of that 30-day period while they're out. So Sublocade also, it's not just being used in that pilot, of course. There's been quite a bit of experience with it in some of the hospital practices. And the reports back from the clinicians and the patients has been very, very favorable, that not having to do the daily dosing has been helpful. From the vantage point of the jails themselves, of course, the jail administrators really like the program because it eliminates the diversion of the pill or film version of buprenorphine, which can very quickly end up in the jail as a commodity that's traded for other commodities and services. So I think you can see that I have quite a bit of sympathy with the person who's asked the question that, why don't we do more of that? Dr. Springel has said the retail cost of one shot of Sublocade is about $1,900. Once out of incarceration, Maine Care is paying close to that amount for that medication, not the full retail amount, but a healthy amount. So it's really the cost that has made it so difficult for other jails, frankly, or the Department of Corrections to move more to injectables. If the price comes down, if the state is successful in getting a waiver so that the federal government, the Maine Care, could cover the final 90 days at least of incarceration, you'd see, I think, a lot more use of the injectable version. The next question is, I think it's a good point. I'm not sure there's a question so much as acknowledging that not all hospitals are this. There's 33 hospitals. There are some that are really doing a very conscientious job of helping people when they come into the emergency department. And we're supporting recovery coaches to be available to such individuals in 10 emergency departments. we'd like to get that to all 33. So this person that works in a hospital is saying that in his case, they always set up a safety plan, which includes supports while they wait on any waiting list. This is now I'm quoting from the questioner. My struggle is finding appropriate bed availability, crisis, sober house, counseling services needed. The wait is so long that the supports have to get back to work and normal routines once again start. These repeat admissions to the emergency department and inpatient are very costly to the patient mental health and also for Maine with hospital costs. I'm hoping we can stress the importance of service needs. My response on behalf of the state is that we will have another 140 to 200 beds available in residential care and more and detox beds within the next 30 days to 1 year. Put an extraordinary amount of money into offering organizations the chance to expand their services, including Milestone and Wellspring. We agree with you. There aren't enough supports outside right now, but there's a lot more than there were. We also have the living room operated by Springel in Portland, the Crisis Receiving Center. And there is talk, not a firm plan yet, but one would hope that with the success that is seen in diverting individuals from the emergency rooms and providing really I think it's open about 12 hours a day, maybe 7 days a week. There's always behavioral health specialists there. It's been quite successful, the data shows, and the need, of course, exists not only in Portland, but I think anyone would like to see similar crisis receiving units in Lewiston, Augusta, Bangor. The need is certainly there. So our strategic plan contains all these elements. You can go to mainedrugdata.org, get the latest copy of our strategic plan, and then the Maine Recovery Council, which has half the settlement money, will also be conducting a public hearing the week of October 23rd, where any member of the public can come and give us their ideas on where the money should be targeted, what the priorities should be. So help is on the way. I wish those beds were open today. Some of them are opening this month, but help is coming. There are going to be more supports outside of the hospital. Ron, this next question is a perfect one for you. It says, some sober houses do not allow persons who are on MAT therapy. Hopefully that changes as well. Can you comment on that?
Yes, Kelly, thanks for that question. So the group I work with, MAR, Maine Association of Recovery Residences, inspects and certifies 77 recovery houses throughout Maine. There are some that are not certified. I can't tell you much about them because I just don't know. In Maine, recovery house certification is voluntary, not mandatory. But of those 77 houses that we do work with, 75% do allow people on MOUD, or also called MAT, MOUD medication for opiate use disorders, such as the ones we've been talking about, including methadone and some others. MAT, medication assisted treatment, it's kind of an older term. Should it be 100%? Probably, but there are those who feel that an abstinence-based, so-called abstinence-based environment is the right environment for some people, and there are people there who, if they needed to take a medicine of that sort, they would go to one of the houses that permits it. That's the current state, but it's also in flux. Things change from time to time, and we've certainly gone from one house in the state allowing it to 3/4. So we're moving in the right direction.
The next question is a great one from Molly. If you have lost a loved one, such as a brother or mother, how does one get interviewed by the panel? I think it's fair to direct your request probably to me. We had 723 fatal overdoses last year. We're not going to be able to do a deep dive into all those cases. So I can't make a guarantee that everybody that would like to have their loved one's case reviewed will get reviewed. But at least we can we haven't put out a notice or anything to entertain those requests, but there's no reason why a request couldn't be sent to me and I can forward it to the team and have the panel look at it. It's just gordon.smith@mainemed.gov. Dr. Moltz, my friend Dr. Moltz, has a great question that, Marcy, probably you may be the best one to answer. It says, in relation to the first question about medication on release from incarceration, what was the medication status of the cases you looked at? So those 5 cases where we looked at recent deaths caused death within very close proximate time to release from a county jail, what medication were individuals on? Do you want to try that, Marcy, realizing that we're not going to be able to tell you exactly in all 5 cases?
No, and I don't, we did this category first. And at the same time we were doing this category, there were changes in the jails that are relevant here. And I think that I don't believe we had anybody that was on buprenorphine in that group. But of course, the rules around, and I'll let Gordon talk about that, the rules around what the jails are doing have changed since we started our work.
That's the right answer, Marcy, is that, David, when we started in 2021 looking at these cases, a lot of these cases might have been in 2017, 2018. It wasn't until Executive Order 2 required or set an expectation that anyone with a substance use disorder in the state of Maine who was incarcerated, Governor Mills expected them to be offered medication for that treatment. And since that time, now the Department of Corrections, 44% of all the residents of the Department of Correction facilities are on medication for substance use disorder, and all of the jails have programs. We're not at the point where every single person with a substance use disorder gets to pick between methadone, injectable buprenorphine, naltrexone. Ideally, you'd want that decision made just between the patient and the medical team. We're not there yet, but there is a medication program in every single jail, and hundreds. I get the data every 3 months on who's been, how many people are on it in each jail. And when you consider that this was done in the middle of a global pandemic, when it was a major obligation on the part of the jails to protect their staff and residents from COVID, I think I give them a lot of credit, particularly those that have quite a large percentage of their residents on medication. That would include certainly places like the Aroostook Jail in Holton, the Washington County Jail in Machias. How do schools educate about overdoses? I want to answer this one because there was a statute passed, presented by students themselves, and it was enacted that requires each secondary school to offer training on naloxone administration to all the students. Now, again, you're required to offer it. They're not required to accept it. And it's an unfunded mandate. So there's some questions as to whether it could really be enforced. But 97 schools today have Narcan at the high school, at least. And the schools are moving quite rapidly towards the educational piece, as well as having naloxone available. I give the Department of Education a lot of credit on that. Our friend Leanne is asking Maine, or making a point at least, that Maine CDC supports each county to provide education in the schools. Thanks, Leanna. That's true. The governor made $1 million of additional money available for each of the members of the Maine Prevention Network to make a particular link to 3 middle schools in their public health district. And that some of those just started last month in September. There are grief support groups for children that have lost parents. Help me with that, Shelley and Ron.
You know, there really aren't. I've thought about putting one together because I have grandchildren who lost a dad. But I mean, as far as statewide, I don't know, but I know in the Penobscot, Hancock, Washington, and Aroostook County areas, there are not in Piscataquis.
Okay, we'll work on that. There's 21 recovery centers, of course, and we'll think about those recovery community centers. And again, go to the Know Your Options website, do the drop down option by your county, and there may be some groups there that that the four of us aren't aware of. Just a couple more questions because we're running out of time. Already 2 minutes over. MAT is a good tool in the toolbox of recovery. It shouldn't be the only tool. Ron, I think, has made that point well. Currently, there's a group at the barn Thursday, 6 to 7:30. I don't know whether that's a group for kids or not, but we'll certainly take a look at that. I think the rest we'll answer in writing as we did last month. Does Dr. Nalaboff, this is an easy one, does the panel submit a report to the legislature with the findings and recommendations, and that report made public? We're not required under the statute, Jay, to make any reports, but we are preparing a report that we intend to make available to all the branches of government, including the legislature. We just want it to be reviewed first by particularly the Attorney General, because he, under the statute, retains the authority to decide what is published of the work of the panel. So we'll answer the rest of the questions. I don't want to keep it after 12:30. There are maybe 3-4 other questions. Jennifer Edwards in Auburn makes a good point that the Center for Grieving Children in Portland, a well-known organization, would be a great partner to outreach about developing a support structure for children who have lost their parents to an overdose. We'll follow up on that, Jennifer. It's a wonderful organization. I'm somewhat familiar with it. So with this, I want to thank Dr. Sorg, Shelley, and Ron, and all of you for hanging in there with us today. I hope you enjoy the long weekend and Indigenous Peoples Day on Monday, and hope you'll all join us for the Northern New England Poison Control Center